Hello, ladies and gentlemen. My name is Professor Roudsari, and this is the recording for your lecture on indirect restorations. Let me share my screen and we go through the slides together. So before we get started, this is an introduction to use of indirect restorations, and this symposia comes to complement all your teaching and learning on the Phantom Head so far. So what I try to avoid in this lecture was to go back through the absolute basic principles of indirect tooth preparations that you have already covered in Phantom Head. And instead, I wanted to share a bit of insight and wisdom behind choosing indirect restorations when you choose what type of design, what type of material, what type of patients, etc., etc. So what I'm hoping to do is to give an overview of the use of indirect restoration in dentistry. And as part of that, I will be hoping to cover the indications, some preparations, specifications, how you decide to choose what material you would like to use for your indirect restoration. And finally, I'm going to have a bit of debate and discussion on longevity of indirect restorations. So maybe the first question you would like to start with is that why do teeth need restoring? And it could be for a variety of reasons. Maybe I can put them into these categories, and I'm going to talk about each of them for a couple of minutes. So loss of tooth tissue probably sounds obvious, and one of the biggest reasons for loss of tooth tissue is indeed the dental caries. And if you look at data in England, unfortunately, we're a country with a rather high dental caries risk and high dental caries incidence, and 1 out of 4 children below the age of 5 in England do have caries, which is obviously costing government significant amount of money. This data is rather old, but still you're looking at in excess of £50 million a year spent in the UK for extraction of teeth for patients who are under the age of 19. Now, obviously, demographic do have an effect on the incidence of caries, and looks like people who are coming from better socioeconomic status, they will have less decay, and yet in those patients, you can see that 20% of such individuals are affected by dental decay, in opposed to those with lower socioeconomic status, whereby it's about 30%. Now, probably the next big thing after dental caries when it comes to England is the tooth surface loss. And we know that in England, 100% of adults have got some degree of wear. And out of these, obviously less proportion into the dentine and a much smaller proportion into the pulp. And we know from evidence that as people age and become more senior in aging, the incidence of severity of wear increases. Probably the next category which can come under loss of tooth tissue is dental trauma. And dental trauma is one of those unfortunate incidents in anybody's life, but it normally has got significant and serious aesthetic consequences. Now, if I'm not going to go into the topic of dental trauma at all, because it's not within the remit of this lecture, but we will have lectures in future on dental trauma. But in the meanwhile, one really good resource which I can refer you into is the Dental Trauma Guide or the Dental Trauma UK. Dental Trauma UK, you can sign up into the website. It's not too expensive per year, but you will have access to incredible amount of knowledge, papers, as well as videos showing you how to deal with a variety of different dental trauma situations. Definitely worthwhile a subscription. Now, the next big thing probably, especially for our generation of dentists, is the aesthetics. And aesthetics play a big role in day-to-day status and day-to-day play of every individual. And obviously, people are a lot more exposed to social media and being in front of the cameras, and aesthetics, especially their facial aesthetic and dental aesthetic, is a big thing. So a lot of times we are seeing more and more of patients who are concerned about how naturally anesthetic their teeth look like, and they could be like a justification of when you want to go ahead and restore them. Now, having said that, though, there are some individuals who are unfortunate that, like, they are born with not very aesthetic looking teeth. Examples are people with amelogenesis imperfecta or dentinogenesis imperfecta or other possible congenital conditions which make teeth not looking aesthetic. Sometimes medications can become a problem. The most famous of all is tetracycline, and that's when it is consumed by a pregnant mother or at the very early age, while either deciduous or adult teeth are still forming. And as you can see, they can cause significant darkening and anesthetic appearance of dentition. When teeth go non-vital, they can also pose aesthetic problems. Now, when teeth go non-vital, if you do have necrotic pulp, a lot of time the byproducts of the denaturation of the pulpal products and the blood vessels, they can cause this kind of black-gray appearance that you can see on the screen. You may also have, for example, concussion trauma to the teeth, whereby you would have a bit of bleed from the pulp, and then you do have obviously heme within your red blood cells, which will then, when it starts to denaturate and it starts to fall apart, it starts to give very colorful products of a blue and green color, and they all can actually make the tooth look very unsightly. Oftentimes, when you have a root canal done, especially on the anterior teeth, it is possible that part of the pulp tissue is left, typically the pulp horns in the central incisor, and they can then produce byproducts of heme and have the colors. Or oftentimes, when you have a root canal done, it's possible that, the dentist does not cut the root filling material below CJ, and then the sealer, which a lot of times exists as part of your obturation products, may then cause discoloration in the teeth. Sometimes you got patients like this one that you can see on the image. So this patient had a concussion injury to the upper right central incisor, and the tooth retained its vitality. But then when you go ahead and take an X-ray, you see significant pulpal obliteration, pulpal closing in the upper right central incisor. And essentially the dark yellow mature color you get is because of all this tertiary dentin which have been forming and therefore making the tooth look really yellow. So what you're seeing is actually that very dense kind of dentin. And then the big question in these cases is that if the tooth still has got vitality, normally they don't respond to endophrust, this electric pulp tester that actually can penetrate through this kind of deep dentin and actually give you a signal, but there's no peripheral pathology. And these are the cases that you really don't want to go ahead and root canal. They're incredibly difficult to root canal, and the pulp is vital. So these are quite difficult to manage, and you have to look into pure restorative options without the root canal to try to fix them. And obviously, people may not be happy with how their teeth are aligned. There might be spacing, there might be crowding, and these patients would need some form of restoration if they want to enhance and improve their aesthetics. So sometimes you have to restore teeth as part of a bigger treatment plan to help with the construction of other prostheses. What do I mean by that? So for instance, if you're going to make a partial denture, sometimes your undercuts may not be in a favorable position. So in those cases, you may want to go ahead and electively add some composite in order to change the height of contour of the tooth, and consequently, you would change where your undercut is. Sometimes teeth which are broken down, you would decide to, instead of using a direct restoration, use an indirect, for example, a crown. And then in those crowns dictate where your ideal rest seats, where your ideal undercuts are going to be. So for example, in this case, We do have a number of milled crowns. Now, milled crowns are porcelain fused to metal, typically. Crowns whereby the lingual or platal surfaces are milled based on your path of insertion. So then the denture has got very limited paths of insertion, which helps massively with its retention and stability. And in this case, as you can see, the arrows in green are pointing into those parallel walls which have been milled. And then what we did was in the yellow arrow is a premolar, which we placed a stud attachment instead of clasping in that region. So essentially, you've got minimal number of clasps, highly aesthetic restoration, highly aesthetic prostheses, removable prostheses, which also have a really good retention and really good stability. Now, here's an interesting case whereby the patient had two congenitally missing lateral incisors. And as you can see, there are two dental implants in place that are ready for restoration. Now, lots of more junior dentists, they might think, okay, that's fairly easy. We just go ahead and take an impression of those dental implants and put two crowns, and that's going to be a happy patient. But if you pay attention carefully, what I've drawn here with black is where your contact point of the lateral incisor will be on the right-hand side. And what I drawn as a red line is where your gingiva is currently. And if you place a dental implant like that white box which I put in there, you will end up with a black triangle, which is incredibly unaesthetic. So if you would like to ensure your dental implant, in this case, is going to be looking good, you have to keep all of this into consideration. And before you take impression for your dental implants, you would like to go ahead and add some composite to the central incisors and make them look a little bit more square so that you're preventing those black triangles from forming. Now, sometimes you have to restore adjacent teeth to a gap in order to restore the gap. For example, in the case of this bridge work whereby the canine and tooth number 5 have been prepared, and then there is a pontic of your tooth number 4 in there. So that was a very brief summary of when you decide, or actually what are the situations whereby you will be restoring teeth. The next step is really the decision on to restore teeth. And essentially, when it comes to looking at broken down teeth and deciding what to do next, you do have a variety of options. Your options are direct restorations, indirect restorations, or taking the tooth out. So when it comes to direct restoration, essentially just to make sure we're talking about the same terminology, is any restoration which is done there and there by you on the dental chair and does not require laboratory production. The examples are your glass ionomers, composites, amalgams, everything which is a plastic material which goes into the mouth, and then it will either set on its own or you have to light cure them to reach its final set. Now, indirect restorations are anything that you have to take an impression of, and they're made outside the mouth. Now, traditionally, it's a impression done in, for example, a polyether or a silicone material, and then it goes to a conventional laboratory for production. But nowadays, it's more and more of digital impression. And then sometimes you may have in the office CAD/CAM devices which you can mill or print your restoration, or they go to your commercial lab and then you will receive the production in the post a few days later. But either way, for these materials, because you have to take some sort of impression and the production is done outside the mouth, although it may be done in your surgery, just in the corner, a machine milling your zirconia crowns, but it's called an indirect restoration. Finally, when you decide that, you say, okay, then, direct restorations are not going to be suitable here, indirect is not going to be suitable, let's just take the tooth out and just start fresh and think about the replacement options. Now, the big decision here is actually or the big challenge here is how you make such decisions. And the best analogy is, for example, if you come to me and say, oh, Prof Roudsari, what car do you think I should buy? Obviously, when you go to a car buying website, there are hundreds of thousands of cars at your disposal. And every person's situation is different, and then you may just choose something differently. For instance, you might come to me and you say, I am in my year 3 of dentistry and I really enjoy Manchester. My plan is I'm going to finish my studies. I'm going to find a job in Manchester. I'm going to stay in Manchester. I'm going to stay in England and everything. And I need a car that I just buy it and just forget about it for many years to come. So in those kind of actually cases, I will be probably looking at really pushing your budget to something that's going to last you for 7, 8, 10, 15 years, if that makes sense. I might just tell you, I'm not advertising for Audi, but I mean, you go and buy a more sturdy car. Once you come and tell me, Prof Reza, I'm just like, a student here. And then as soon as I get to my year 5, I'm just going to go back to another country. I'm going to go to Australia and work. I'm going to go to US and work or whatsoever. I just don't want to stay in the UK. And I just need a car to help me for the next 3 years. And I don't care after that. I'm just going to throw it off a valley and just get rid of it. And then in those kind of cases, obviously you don't want to break the bank and you go for a much more economic version of a car. It still gets you from point A to point B. And if it breaks down on your last day in Manchester, you're not going to actually get worried about it at all. You're just going to give it to the scrapyard, if that makes sense. So with that in mind, you come back to looking at these and deciding which one you're looking at, like a couple of years, 10 years, and that's how you have to make a decision whether a direct will work here or indirect will work here, or you just have to take the tooth out. For me, and this is just completely a rule of thumb, is not a scientific thing. A lot of times, if I'm going to decide whether sacrifice or restore a tooth, either direct or indirect, I just have to think about, is that tooth going to be still in my patient's mouth in 5 years? If the answer is no, very likely the tooth is going to go. But the answer is yes, then I will try to save the tooth. However, as I said, there are exceptions to it. It's not a rule, and I'm going to show you an exception here. So the picture you see on the bottom left-hand side is a patient, lovely patient came to me and fractured her canine about 4 millimeter below gingiva. And the best option in her case was a single dental implant. So crown lensing was not possible. The patient had a very gummy smile. And if I had to crown lengthen around those teeth, then her whole smile would have been interfered and would not be aesthetic. Ideally, I wanted tooth out and a dental implant. And she told me that she, at the moment, has got 2 of her daughters in the university. In 2 years' time, both daughters will finish their studies, and then she will have enough time, enough budget to go ahead with the dental implant. So essentially, all I wanted was a restoration, which is going to last this lady 2 years. So what I did was, I did a root canal of this broken canine, and I put a fiber post, obviously very difficult, almost impossible to control the hemorrhage and bleeding. So later on, I had to actually use soft tissue enhancing techniques in order to improve my chance of moisture control. But what you can see is on the right-hand side is the final restoration, which I made it as a lab-made composite in situ to restore the canine. So the picture on the left and the picture on the right, they only got 3 weeks in between them, but I did a lot of work in order to actually stabilize the gingiva for this lady. And this restoration lasted 3 years and 10 months. So it surpassed our expectation. The patient, in the meanwhile, managed to save enough. Obviously, the daughters were now graduated, and then she came and had the tooth removed and a single dental implant placed. So in this kind of cases, yes, the tooth was never going to last me more than 5 years, but the patient only wanted a couple of years, and we obviously surpassed the expectation, and we managed to keep it until the next phase of treatment. So sometimes you have to think about, will this tooth be there until my next phase of treatment? And in this case, was obviously a single dental implant. So there are points to consider. There are patient factors and there are tooth factors, which I would like to go into a bit more depth with you. So when it comes to patient factors, obviously oral hygiene and motivation is a big thing. If patients cannot keep their oral hygiene up to your standards and they're not motivated, there's no point going with complex treatments. You have to try to keep things simple, try to do as minimal as possible. And a lot of times you're looking at direct provisional restoration rather than anything indirect until you manage to improve the patient's oral hygiene and make them motivated. Sometimes you got patients who are motivated, but they just genuinely do not have manual dexterity in order to maintain their oral hygiene. And you have to be very careful that, like, what kind of restorations you're going to provide them. Can they clean around it? It's lovely to be able to do bridge work and everything for everybody, or dental implants, but then if they cannot clean it, it's going to fail. And it's really, sometimes they're really challenging to then control the state of failure for such patients. Now, medical history is a big thing. And I'm showing you an example of this case whereby you can see some non-healing extraction sockets, and they have been like that for in excess of 2 months. As you can see here, you can see some necrotic bone of where teeth used to be interproximal, so interproximal bones where it used to be teeth in the sockets in between these, and is never healing because the patient has been on alendronic acid, on bisphosphonate for in excess of 10 years. The dentist did not take a good medical history and unfortunately ends up with this deep-seated infection and necrotic tissues. And these cases are incredibly difficult to control and manage because the bone does not heal. And essentially, they're a huge challenge in order to try to stabilize them. Sometimes, unfortunately, they can be fatal. Mouth opening is another big thing. So obviously, in order to provide any form of direct or indirect restoration, you need to be able to get in there quite comfortably to be able to produce acceptable procedure. But for a variety of reasons, you may encounter patients who do have limited mouth opening, and then your options will be incredibly limited in terms of what you can or cannot provide. And finally, somebody has to pay for it, whether it's NHS or whether it's the patient or whether it's the insurance. So somebody has to pay for it. And there is sometimes, although there are options available, but not options viable financially to proceed for the patient, if that makes sense. So I touched about patient factors. I'm going to look a little bit into tooth factors, and probably the biggest of tooth factors, the remaining tooth structure. Now, I'm going to show you this molar tooth, which has an old amalgam filling and part of the cusp is fractured, and the patient comes to you and you would like to restore the tooth. And essentially your options are: one, you put another direct restoration, whether it's another amalgam or another composite, or two, you would like to go ahead and do an indirect restoration, whether it's an unlay or a crown or a 3/4 crown, that's irrelevant, but essentially an indirect restoration, or three, take the tooth out. So I want you to just think about it for a couple of seconds and see what you would like to go. Direct, indirect, or take the tooth out. Okay, so whatever you decide, just make sure you remember it. I'm going to come back to that in a second. So let's have a look at this tooth. So if I consider the periphery of the tooth as being 100%, we've lost one cusp. So 25% of the tooth is gone. By the time you remove this amalgam, that's a further 35% gone. And you can see that there's a bit of recurrent caries under your distopalatal cusps. That's another 5% gone. And if you look very carefully, you probably can see a crack going toward this cusp as well. So there's a chance that you may lose this whole of the cusp. So you'll be only left with maybe 40% of the tooth, which is reasonably intact. So with now this analogy in mind, would you like to go with a direct restoration or indirect restoration in this case? Or maybe even take the tooth out? Anyway, I'll come back to that again in a second. So there are a couple of really good papers by MacDonald and Bandelish, and they looked at the tooth restorability index. And the way it works is, so when you look at the tooth from above, from the occlusal surface, you divide it into sextants of mesial, distal, and then you will have mesiobuccal and distobuccal on the buccal, and mesiolingual and distolingual on the lingual of the tooth. And then for each sextant of the tooth, you award them with a score from 0 to 3 based on how much dentinal wall there is. So if there is none, you give them a 0 and you go all the way for 3 where you've got adequate amount of wall. For example, if you look at their paper, here's an example they put in there, and they had photos of this essentially tooth, and then they have divided the tooth into sextants, and they give the tooth a variety of different numbers. And if you add them all together, so 1, 2, and 3 is 4, plus 3 is 7, and then plus 2 is 9. So the score is 9 for these twos, and it's just telling you then, depending on what you score, whether you go with a plastic restoration or an indirect restoration. And again, as I said, like, it's not just as simple as you look at the twos and decide direct or indirect. So this is a kind of actually guide to help you, like, choose whether it's going to be direct or indirect. And I'm just going to show you a couple of more papers, one by Rian Messer and the other one by Goldanas Lopez. And essentially, both papers have done similar kind of, like, procedure, whereby they looked at the premolar and then they applied force on the premolar occlusally until the tooth breaks. And they're actually, so they're looking at, I beg your pardon, one of them is actually looking at the flexure of the cusp to see how much they flex. And so that the force they applied was 115 newtons. And if you look at an intact premolar, the cuspal flexure is only 2 microns. And then as you're losing more and more of the tooth structure, then the cuspal flexure increases substantially. And the worst is when you have lost both marginal ridges, i.e. you've got an MOD cavity, and also you've got a root canal access in place as well. So from these two articles, we can conclude that the presence or absence of marginal ridge is essentially the game changer. If you lost both marginal ridges, then it's very likely, and also you've got a root canal access, it's very likely that you will be better off doing an indirect restoration rather than direct restoration. And you put Bandelish and McDonald's paper together, and then you're looking at remaining cuspal structure and position of the margins also being very important factors. So marginal ridge, dentinal wall, and the position of your margins are your 3 incredibly important factors when you're looking at the tooth. So shall we come back to our tooth? So let's look at the marginal ridges. So we do have a marginal ridge on the distal, so I put it as green, but we don't have a marginal ridge on the mesial. It's been restored with an amalgam. So I put the red there. And then you're looking at the remaining dentinal wall. So on the buccal, you do have 2 good cusps. So you have plenty of, like, dentinal wall there. So they're green. On where the cusp is fractured, you have gone a slightly even subgingival. There's no wall there. And then it's questionable after you remove the caries and the old amalgam to see how much you've got on the cusp, which I have marked as amber. And then if you look at your margins, so the 2 margins of the buccal will be on sound dentin. The one on where the fractured cusp is almost subgingival. And then I genuinely don't know what's going to happen after we remove the decay and the amalgam on the distoplatal cusp, and then see where the position of the margin is. But as you can see, these 3 factors help massively you decide whether it's going to be a direct, indirect, or probably the tooth is not worth it as to go. So other things to consider is your periodontal status, because at the end of the day, you have to make sure you do have good amount of bone and a good amount of gum and periodontium supporting your teeth in order to carry any sort of load. So probably a classic and important law, well, let's say law, but again, it's a kind of like, a helping point is the antes. And the way the antes law work, and I'll tell you in a second why it's not a law, but essentially it's known as antes law, is that you look at the amount of area that is supporting the periodontium of each individual tooth. And I put the table from Antes paper in terms of, like, different teeth and whether it's maxilla or mandible and what the area is covering on the right-hand side in the black table. And the way it works is, so let's say, for example, in this case, you're using a canine and a second premolar to replace a first premolar. So for maxillary canine, your area is 204 millimeters square, whilst the same for the tooth number 5 is 140. You add them together and it gives you a value which is 344. Now, 344 is more than 149. So essentially, and this law is saying that whatever abutment teeth you're using, you add the periodontal area together, and the sum of those should exceed the sum of periodontal area required for the pontic teeth. Having said that, though, if you look at a couple of papers which came out, probably the most famous of them was by Linde. They looked at teeth which were severely periodontally involved, and they were completely against Antes law, and they showed that as long as you manage occlusion well, then you don't really have to count. So essentially, Anti's law is a good guidance. You still can use it as a general rule of thumb thing, but again, it's not a strict law. So it's really actually a guidance rather than a law. And reminding you, whenever you're looking into periodontal support, things you have to remember is the clinical attachment loss, which is essentially you're probing depths and recession together to see how much of the tooth is left. So again, if you go back to Anti's law, it's looking at healthy teeth when people are affected by periodontal disease and they have lost clinical attachment, then it really doesn't matter how much you calculate, things will not actually add up, if that makes sense, because you're not using the same values as of Antis. So furcation involvement, and if you don't know where furcation is the area in between the two roots, and depending on what grade of furcation involvement you're looking at, the prognosis of the tooth would be completely compromised. And whether you're looking at horizontal defect or vertical defect or a bit of both, then there's a big chance of tooth being lost in the higher degrees of both horizontal and vertical furcation involvement. And these kind of cases, if you do have furcation involvement, you really have to know your perio to ensure that you're not going to try to save a tooth, which is not going to have a kind of like a good prognosis. Endodontic status of the tooth, again, is very important, and you have to determine whether a tooth, before you're going to use it as part of a prosthesis, whether it's vital or has got pulpal inflammation, or whether you require a root canal first. And also lots of your restoration that can cause pulpal irritation and might lead to pulpal death. So here's a table borrowed from a paper published by one of my good friends, Dr. Shiana Elias, and she's summarizing what's the chance of pulpal death under crowns and bridges, and you can see that there's quite a big of variance between these. So if you look at the crown column, which is the second before end on the right hand side, so essentially, the chance of pulpal death on the crown is anything between 3% to 20%, which is a huge variance. And again, with the bridge, can be anything from 10% to almost 1 out of 3 dying. And it probably actually really depends on, like, the techniques, the choice of marginal ridge, the amount of prep that the clinician has done, and all the other things which can actually irritate the pulp or not. And hence actually there's such a huge variance between different people, if that makes sense. So pulp capping, if by any chance you're prepping your tooth and the tooth gets exposed, do you pulp cap and continue with your indirect or not? And there's a classic paper. I say classic paper is 2000, and it feels like it was only 2 days ago, but obviously it's now 24 years ago, by Bartel, which they looked into all the pulpal exposures they got and just decided to see how long they last before the teeth die. And essentially, if you do a calcium hydroxide pulp capping, in almost 50% of the cases, in 5 years, the tooth is going to die, and 80% in 10 years. And essentially, the conclusion of the paper is if you expose a pulp, and you're going to put a crown on the tooth, just do a root canal and just don't wait, because otherwise you're going to put the crown and then 5 years later you have to actually drill it back in. Having said that, though, again, so now these are classic papers because they use calcium hydroxide. Nowadays with MTA and biodentin, things would be considerably different. But there is no paper at the moment which is looking into these newer materials and see the chance of success, or not yet at the time of just doing this lecture. Occlusal considerations: do you have enough space for your restorations? And you can see in this image that essentially your plane of occlusion for the mandible is the black line, and then you can see where your canine has over erupted into, leaving you with hardly any space to restore. And also, when you're looking at occlusal consideration, root canal treated teeth are of importance to consider. And because root canal treated teeth are a lot more prone to fracture for 2 reasons. One is because they have lost a lot of tooth tissue because of all the drillings that we do as dentists, and also because patients will lose perioception around these teeth. I'll come back to that in 2 seconds. So I told you about the papers by Rian Masser as well as Gonzalez Lopez in terms of flexibility as you're losing more and more tooth structure. more interesting is actually this paper, which is a classic by Rando and Glantz. And it's pretty much like, one of the reference papers to go to, which nowadays you would never be able to get ethical approval to do such a test. And essentially what they did was they had a research assistant who happened to have two premolars on one side, which had been root canal treated, and two healthy premolars on the left-hand side. And what they did was they gave the patient a gauge to bite into until it hurt. So they had to stop. Now, I'm not putting the actual figures in. I'm just putting figures that you can digest and understand. Let's say, on the scale, the patient had to bite up to about 100 kilos before it hurt, and they had to stop. When they put the gauge on the side of the root canal treated teeth, the patient had to put almost twice as much, like 200 kilos, before they felt that it's hurting and they have to stop. But if you have to remember, you do have the nerve inside the tooth, and also you got nerve within the periodontium around the tooth. And a combination of these give you the perception whether it's going to hurt your body and you have to stop and just don't have to continue. So if you do have root canal treatment, it's twice as much before your brain tell you you're breaking something, stop. Now, what they did was they brought local anesthetic and numbed the patient on the vital side, and then they redo the test and realize then the patient goes to 200 kilograms before their brain is going to tell them to stop. Essentially, the conclusion is whenever you do a root canal treatment on a tooth, you lose all the perception which is possibly coming from the pulp of the tooth, and therefore your patient is going to put twice as much force on a root canal treated tooth before they know it's too much. So it might be sometimes too late, and they might just fracture the tooth without even realizing it. So here's another paper by Ibrahim, which is showing essentially the fracture load required to fracture a tooth based on the surface area of the tooth left, which, as you can see, is quite obvious. So the more tooth structure you've got, the harder it is to fracture the tooth. But what I was interested in this paper was not actually this, is the fact that the most important wall for you to have in a tooth to make it kind of resist fracture is your platal wall or your lingual wall. So always a platal wall and the lingual wall is the most important wall for you to have enough of in order to help resist fracture in a tooth. And finally, aesthetics obviously is an important thing to consider, and aesthetics is a very big topic and definitely not within the remit of the lecture today. So let's look into some of the preparations, and then in terms of prepping, whether how to make a decision whether you want to have an inlay or an onlay done, or whether you want to have a full coverage or partial coverage done. And then what do you want to make it? Do you want to make it as composite? Do you want to use a form of metal alloy, precious or non-precious, porcelain fused to metal, porcelain itself, ceramic? So, how do you make the decision? Now, to be honest, I think these decisions come secondary, and what is really, really important are the principles of prep. And if you have not come across Schellenberg's Fundamentals of Fixed Prosthodontics, you have to read this book. When I was at your age and your stage, I read this book back to back, cover to cover, around 3 times. By the time I graduated, I had read this book about 12 times, and I'm not exaggerating. It's a fantastic book. It's got everything you need to know about principles of indirect restoration, dental materials, occlusion. And if you know this book really, really well, you will become a much, much, much better dentist automatically. Just as I said, I read this book at least 12 times before I graduated, and I still got a copy of it, the newer version. It's fantastic book, 100% recommended. And if you look at Schellenberg's, there are a number of things that are considered as his principle of tooth preparation, but most important is to preserve the tooth structure. No dental material would be better than actual tooth structure. So if whatever of the tooth structure you can preserve, you are winning the game. Another fantastic book is by Professor Rosenshell, The Contemporary Fixed Prosthodontics. Again, fantastic book. And it's in his book, he puts essentially his principles of preparation into the biological, mechanical, and aesthetic consideration. So biological, again, is to conserve as much tooth structure as possible. And he's looking at retention resistant forms, and obviously anything which is to do with making restorations as aesthetically as possible. But you can see from both incredibly famous names that really the biggest thing you have to remember is you have to preserve as much of the tooth structure as possible. And there are papers which are looking at different preparation designs to see how much you have to drill off the tooth in order to make room for your restoration. And the example is the one by Randolph and Sorensen, which I've got at the moment here. And these are, for example, some of the remarks from the paper, that whenever you can do an inlay, they're the least of the aggressiveness, so they're very conservative. A porcelain fused to metal or a metal ceramic crown removes 14 times more tooth than, for example, an inlay. Your porcelain fused to metal, to be honest, is one of the most aggressive preparations, and it removes 20% more of tooth structure compared to a gold crown. And all ceramic restoration, again, are less aggressive than your porcelain fused to metal. So to be honest, I have not done a porcelain fused to metal for God knows how many years now. Both at dental hospital and in my private practice, I'm pretty much like, gone completely like into ceramics and zirconia and emax, lithium disilicate, because they're much, much kinder preparation to the tooth compared to your porcelain fused to metal. You might ask, why then on phantom head you have to go ahead and do porcelain fused to metal? It's just hand skills, because with porcelain fused to metal, you do have a shoulder on the buccal, you got the chamfer on the lingual or platal, and just how you blend them together, it requires really good hand skills. So we teach you PFM, so you understand shoulder, you understand chamfer, you understand figures and numbers where your contact have to start, etc. But when you come in the clinic, we try to push you toward more conservative preparation. And it is very likely that by the time you qualify, you will never actually do a porcelain fused to metal in your lifetime. But anyway, so whenever it comes to prepping teeth, you always think about, can I preserve some of the tooth? So always think, can you do a partial coverage versus a full coverage? Can you do 3/4? Can you only do, for example, the buccal and part of the lingual or platal? So try to make them 3/4 if possible. So the less you prep, the better for the tooth and your patient on the long run. And whenever possible, keep your margins supragingival. Or know that if you go to Rosenschel and Schellenberg, they are talking about subgingival margin, but they are from the eras of the porcelain fused to metal, whereby they have to hide metal. In our days of resin dentistry and bonding, I hardly have to go subgingival unless, there's already a subgingival caries or fracture defect. Otherwise, I keep all my margins always supragingival. Worst case scenario, equigingival, but supragingival margins are definitely go-to unless you got a really valid reason to go any further down. So just covering a couple of things. So prepare axial walls with minimal occlusal coverage or taper as much as possible, and try to follow the anatomy. And obviously your retention is preventing the removal of the restoration along the path of insertion. Resistant prevents the removal of restoration in oblique direction, which we had covered in our partial denture. And then when it comes to retention, there are a number of things which you have to consider. So your dislodging forces, the patient's occlusion, where the tooth is positioned in the arch, and how much of the occlusal load dynamically is going to get. Geometry of the tooth preparation is quite important, and in particular, the taper. So the taper is the relationship of one wall to the long axis of the prep. And in a case of an external essentially wall, it helps your indirect restoration to come in and out. And in terms of internal walls is when you're having an inlay to put it in and out. And what your taper helps you to do is allows you to visualize your prep. It stops any undercuts from forming, and also it permits better seating of your restoration during cementation. And an ideal taper in books is 3 degrees. And when you add the 2 tapered walls together, so 3 and 3 becomes 6 degrees of total occlusal convergence. So that's ideal. And if you look at this very classic paper by Jorgensen, you're looking at as your taper increases, your retention massively drops. So hence they were actually suggesting a 6 degree as the ideal. But the problem is 6 degrees almost impossible to do by humans. So when you're looking at clinical data, for the very experienced people, you're looking at 10 degrees of total occlusal convergence, and for essentially more junior dentists, you're looking at like more toward the 22 degrees, and these are the real things which are achievable on a clinic. Now, passive insertion is an imaginary line that a restoration is placed, and that's very important for you to consider before even you take or pick up your handpiece, because you have to make sure at what angle your restoration is sitting, and then that's going to be your long axis for all your preparation. And the thing is, if you get it wrong, then your restoration may never sit. So it's super important that you consider your passive insertion before you pick up a drill. Now, when you do have taper and you look at the tooth vertically, you should be able to see all your margins. So if you cannot see all your margins straight away, it means that you do have an undercut somewhere. And this is true for the case of a bridge. So if you do have a bridge, you have to look at one preparation via your mirror and tilt your mirror until you can see all your margins. And then without changing the angle of your mirror, you go to the next abutment tooth and you should be able to still see all the margins. If you cannot, it means that you don't have parallelism and the wrong passive insertion. So now, most of the time, if your teeth are reasonably straight within the arch, for a full coverage crown, your passive insertion would be parallel to the long axis of the tooth. So for your 3/4 crown on the posterior teeth is exactly the same. So your passive insertion would be parallel to the long axis of the tooth. So the exception is if you're doing a 3/4 anterior crown. In this kind of cases, you have to make sure your passive insertion is parallel to the mid-third of the buccal of the tooth in order to allow good thickness on the incisal part and better aesthetics. Now, looking at resistance form now, if you do have longer preps, then you will have increased surface area, so improves the retention, but also lens helps you in order to stop dislodging forces. So if you do have a tall preparation, it will stop your dislodging forces from pinning off the restoration of your preparation. And sometimes you may have situations where you have very short teeth, and if you do have short teeth, you have to somehow interfere with what is known as essentially the arc of casting. And you do that by placing grooves and slots in order to make that kind of like an arc much narrower and much smaller, so the restorations do not simply fall off. Now, if you go to your handbooks in your phantom headroom, you will realize that there are a variety of different preparation suggestions, depths for your functional cusp and non-functional cusp. Now, just to make sure you understand functional and non-functional. So if you do have a patient in a class 1, and now you're looking at the patient from the side, essentially your lingual cusp of the bottom is protecting the tongue, and the buccal cusp of the up is protecting your cheek. So the ones which are protecting the tongue and protecting the cheek are called the non-functional cusp, and therefore your buccal of the lower and the plateau of the upper then become functional. So that's what I mean. So you're looking at the different values for your all metals restorations, porcelain fused metal, and all ceramic in terms of how much preparation you need. And you can see with your all ceramics, the preparation suggestion or the depths we are recommending is about 2 mm, which is quite a lot. So also, what's very important to remember is that when you're doing the occlusal reduction, you have to follow the anatomy of the tooth. And if you go flat, you will have too little of reduction in one area and too much in one. And if you go too much and flat, then you've got a huge amount in one area and hardly anything on the other. Now, let's just tease your brain a bit. So I'm looking at this paper, and this paper, what you're looking at is 3 different preparation design. So one of them has got what we tell you. So they have done 2 mm of occlusal reduction and 1.5 mm of chamfer. In the second cohort, they've done 1.2 mm of occlusal reduction and only 0.8 mm of chamfer. And finally, in the third group, they only done 0.8 of occlusal reduction and 0.5 chamfer only above the contact, so they have not opened the contacts. And what they've done is they made steric restorations, which are IPS and press, and they've done 5 years worth of cycling loading. So this is all laboratory-based studies. And what they look at is the occlusal veneers, the third group they keep pinning up. But the restoration on the traditional prep and the minimal prep, they both exactly did the same. So whether you do what we tell you as 2 millimeter occlusal prep and 1.5 over axial prep, or doing much less, in the laboratory study, they have done exactly the same. Does it not make you wonder? Then we are probably removing too much tooth structure unnecessarily. Having said that, hold that thought on that paper. I'll come back to it in a little bit. Here's another paper. And they're looking at even less preps. You're looking at 0.7 occlusal reduction and very minimal axial reduction. And what they did was they looked at composite indirect restoration, lithium disilicate, and feldspathic, and they realized that they're all doing fairly similarly well, if that makes sense. And here's another paper, again, very minimal prep, almost no prep axially, and only a shell on the occlusal. And they're looking at a variety of different restorations, and they realized that their CAD, Emax, and Impress, they did not last. Their composite resin restorations, the XR, they were all still going strong during the duration of this kind of simulation study. So it probably just gets you wonder what we're teaching you. Is it really necessary? Do we really have to prep teeth as much as it's recommended here? But again, the 3 papers, keep this hold this thought. I will come back to this in a bit. So let's talk about materials. So there are a variety of different materials that you can choose from your composite resins all the way to the ceramics, and they will have an effect on your design of the preparation, because for different materials, you have to choose how you're going to prep them. Do you want deep chamfer? Do you want chamfer? Do you want shoulder? Do you want to have only a knife edge, a feather edge? So depending on the choice of material, you will be kind of dictating how you're going to prep. And also, most importantly, then how you're going to treat the material and what kind of cement you're going to go ahead and use. And I actually, I like these 2 bits because you probably remember many years ago, there was an incident whereby there was a problem with fitting of the window in an aircraft, of a B-Air aircraft. And essentially midair, the glass got detached, and essentially the vacuum sucked the airport out. So it's, as you can see, it's the poor flight engineer who is actually holding for his life to actually grab hold of the pilot's leg, so it doesn't actually go flying out in 30,000 altitude. And miraculously, everybody actually is okay. So they managed to land and bring the captain in, and obviously they had lots of frostbites, but he survived. Anyway, so all I want to tell is it's going to be the same. So if you do not treat your material well, and then you don't choose the right cement and everything, so it doesn't matter how strong your material might be or how good of a prep. If you do not honor the properties of your material, your cement, you're just gonna go with a catastrophic failure. So longevity. This is the last bit which I'm going to cover, and it's on how long this restoration is going to last. And this is probably the most confusing and most difficult of all to actually go through. And one of the biggest problems I've got is actually with the heterogeneity of the definitions. Because a lot of times when you're looking at papers and how long this material lasts, some of them, they interpret survival or they look at survival of the materials, and some of them, they purely look at success. Now, the survival, it means that the tooth still has got the restoration. So I will give you an example. Let's say you've done some anterior composites, and it's still 15 years down the line, the composites are still there, but they look ugly. They have chipped, they have scratched, they've got stains, they've discolored. So they survived, but they don't look great. Whilst if you go with success, your composite, maybe 18 months down the line, they start to stain and they don't look great. So essentially, that's a failure if you're looking at success. Well, if you're looking at survival, then you're looking at 15-year survival. So some papers, depending on how strict the criteria is, something which could have failed in 18 months, they might actually let it go for another 15 years. And some papers allow repairing to still be part of their survival, some don't. So it's really difficult to find papers which are comparing like for like, if that makes sense. And also, as you can probably appreciate, there's a hierarchy of evidence, and you start from small laboratory studies all the way to systematic reviews. And now you have obviously the grade 3 of systematic reviews, which are now also critically appraised by a group of experts. So just really looking at like how far you want to go in a hierarchy. And all those papers which I quoted 2 seconds ago about like how much you have to prep, they're all laboratory work, which are at the bottom. So none of these have been tested and tried in the mouse to see in real scenarios, in real patient, with real mastication, with real saliva, how these materials are gonna obviously work. So at the moment, they're looking at materials in their perfect kind of condition and situation. The other thing which is interesting is when you start looking at your evidence, for example, here, I just put like a longevity of restorative materials on Google Scholar, and you can see papers are coming, for example, they all say like, oh, I don't know, Florida, in United Kingdom, in Finland. Why does it matter? You know, if I'm doing a porcelain fused metal, if I'm doing a zirconium crown, why is it different to somebody in Florida or somebody in India or somebody in Finland? Why does it matter? I'll tell you why. So I was just looking at like, just random papers for the sake of putting it on this presentation. And I came across this publication in a non-famous journal. And there's this patient who has got some wear, and they decided to do a 4-month rehabilitation. Now, if this patient came to me, what I would have probably done after I've done all my examination, one reasonable suggestion would be that you do some surgical crown lengthening, i.e. some gum lifting in the lower anterior, so you've got more of the tooth structure. And then you go ahead with some composite restorations, like essentially, I'm not drilling anything, I'm just adding to what we already got. But obviously with those lower anteriors being so small, we hardly have got bondable surfaces too. So whether composite or crown at a later stage, whenever like the patient is ready. But I would have gone very, very conservatively. And guess what they've done? So they decided to electively root canal lower canine to canine, and I genuinely don't know what was wrong with those canines to start with, let alone anything else. And then put metal post in, and then porcelain fused to metal crowns on top. So with the amount of tools they have drilled, I'm sure Professor Rosenschel will be like, not smiling at these guys anymore. And, my suggested treatment plan would probably last the patient a lifetime. Those teeth are going to fall apart in 6 or 7 years. And there's no doubt about it. And maybe that's why, when you're looking at evidence, it's really difficult because, people who are trained from different countries, they might have a completely different philosophy in terms of how they're approaching patients, and sometimes they're incredibly aggressive, unnecessarily aggressive. And also, when you're looking at evidence, sometimes like going for systematic reviews and RCTs may not be the correct papers to look at. For example, there are many papers, very good papers, which are looking at Kaplan-Meier curves. Essentially, they're longitudinal studies and looking at for how long, restorations, last. So they may not be the highest in your hierarchy, but they give you incredibly valuable, information to go. And also, the methods of different papers could be incredibly also variable. I'm giving an example. So this is a systematic review by Peterson, and Peterson is a fantastic author. And if you go on Google Scholar and put his name, he's got systematic reviews for a lot of really interesting topics in dentistry. And I really recommend actually you read his systematic reviews, at least the abstract part of it. So this paper is looking at the review of survival and complication rates of old ceramic and metal ceramic restorations after an observation period of at least 3 years. Okay, so what they are looking at is in 5 years, all ceramic and porcelain fused to metal crowns, they do the same. In the posterior teeth, looks like the densely sintered aluminum crowns, they're looking at 95% kind of survival. Reinforced glass ceramics are fairly similar, and then you can see like, different variety of things. But what I want to show you is this. So if you look at one of the tables in this study, which is like showing you all the polls of different papers they used in order to come to this conclusion, they always have to tell you how heterogeneous, how kind of different these papers are. And if the p-value is less than 0.05, it means that they're very different. The papers are very different. And you can see how little that p is. So it's not only less than 0.5, it's less than 0.0001. So they're very, very heterogeneous, if that makes sense. So pretty much like mixing everything together. And then finally, a lot of times technology is advancing faster than the research can catch up. So I'm sure you remember when iPhone was first kind of actually introduced, and that was obviously iPhone 3. The first iPhone I got was iPhone 4, and I thought it was, oh my God, it's the most fantastic technology I ever had. I still kept the iPhone 4 because, it was the first iPhone I got. I kept it really nice and clean. It still is an original box and everything. But I will never use it. Why would I use it whilst I've got like, the more advanced generations of iPhone? And the iPhones are coming out faster than anybody can even actually give feedback on how the new, like, iPhone is even working, if that makes sense. And it's the same with your ceramics, and they're coming out so fast with better properties that there is absolutely no way you can do a 10-year study on how they're performing. In 10 years' time, we'll have so many different materials and so many different cements to choose from, and so much better technologies for capturing and producing that whatever we start today is going to be completely useless in 10 years' time. And it's really difficult then to actually get a hierarchy of evidence to support what you want to do. So what I wanted to hopefully cover in this session was that we talked about some decision-making tools for you to decide whether you're going for direct, indirect, or sacrificing the twos. We talked about your preparation techniques, and essentially the message I wanted to actually really hammer down to you is that, yes, you do have some values and some suggestions in your handbooks, and that's what we teach you. But as a dentist, you have to keep up to date, and you have to check the recommended preparation depths and the preparation cements for any material you choose. So you can't just go to clinic and hope that you're just gonna make a preparation, it's gonna work. No, it's not gonna be that. You have to know what material you're gonna use, what cement you're gonna use, and then prepare the twos in order to actually get the best of that material and the cement that you're gonna use. So choice of material, very important because it's gonna dictate your prep. And again, with longevity, at the moment, we do not have enough, well, actually, it is really difficult to catch up with the technology and which is ever like, changing very fast. So that brings me to the end of this lecture. I hope you enjoyed, and have a good day.